So, first of all, I would like to apologize for being unable to be there with you in Crete, but unfortunately, unexpected working commitments make me unable to fly and to be there. However, I thank you very much, Katerina, for this kind invitation. It's a pleasure and an honor for me to be with you and to talk about the role of EBUS-TBNA for the diagnosis of pulmonary tumor. Well, this is my conflict of interest disclosure. Well, you know that the history of bronchoscopy is more than 1 century. And during this century, a lot of new techniques and new technology improved a lot the diagnostic possibilities of bronchoscopy. I highlighted the most important steps that really changed our way to perform bronchoscopy. The first is, of course, the introduction of flexible bronchoscopy in 1966 by Shigeto Ikeda. And the other one is the advent of a flexible transbronchial needle aspiration by Kopp and Wang in 1983. Bronchoscopy changed from diagnostic technique to diagnostic and staging technique. And the last improvement that really changed our way to perform bronchoscopy is the advent of EBUS-TBNA in 2005. These are the pioneer of EBUS-TBNA and the first paper published in 2005 by Mark Karnisk from Copenhagen, by Casimiro Yasufuku from Canada, and by Felix Ert from Heidelberg. These guys showed that with EBUS-TBNA, we could get in the lung cancer staging a very high sensitivity, 94%, regardless the lymph node location or sites. Lymph node location or sites were the most important factor that affected the results of conventional transbronchial needle aspiration. With the advent of EBUS guidance, it doesn't matter about the lymph node location or sites. Well, these good results make EBUS-TBNA to be put as a first-line staging modalities in lung cancer by all the guidelines published after 2005. You can see here, this is a guideline from CHEST, and the needle technique, EBUS or EOS-FNA, is recommended as the best first test for lung cancer mediastinal staging. Well, but with the use of EBUS-TBNA, we realized after some years that the possibility of EBUS-TBNA were not limited to staging of mediastinal lymph node, but we can also use this tool for the diagnosis of lung cancer or of pulmonary lesions. For instance, for the diagnosis of pulmonary lesions adjacent to large airway, for the diagnosis of lower lobe peripheral pulmonary lesions, but also for the diagnosis of pleural lesion adjacent to the mediastinum, for the diagnosis of endovascular lesions. And also, the pulmonologists learn with the use of EBUS echoscope to go through the esophagus. The esophagus is a highway into the thorax, and a lot of diagnoses are possible inserting our echobronchoscope through the esophagus, like paraesophageal pulmonary lesion, pleural lesion, but also it's possible to go behind the diaphragm and to diagnose left adrenal gland metastasis or pathologies or liver metastasis. Well, I would like to demonstrate this possibility, showing you some clinical case of our experience. Diagnosis of pulmonary lesions adjacent to the airway. You can see here, this is a lesion very close to the trachea. and it's very easy to visualize this nodule in the right upper lobe, and to insert the needle and to make diagnosis that in this case was an adenocarcinoma, an squamous cell carcinoma, sorry. The second case is a lesion adjacent to the right main bronchus. It's very small lesion, 1 centimeter. And even in this case, it's very easy to visualize this lesion, putting your echobronchoscope in the right main bronchus, in the posterior wall of the right main bronchus, visualizing the lesion and sampling material. And in this case, the diagnosis was adenocarcinoma. Continuing to speak about lesion adjacent to the airways, we move to another lesion that is similar to the previous one in the posterior wall of the right main bronchus. You can see here how it's very well visible, the lesion that in this case was an hamartoma. But we can go more peripherally. And you can see here a lesion in the left upper lobe, very close to the left upper lobe. Be careful, because in all these cases, in all the cases that I show you, the mucosa is not involved. So there is no possibility to make diagnosis using biopsy forceps or brushing or broncholavage. We have to go through the tracheobronchial wall and to go into the lesion. As you can see here, you can see the echobronchoscope was inserted at the orifice of the left upper lobe bronchus. You can see here the artery, the pulmonary artery, and very easy to visualize the lesion and to make sample. And it was again an adenocarcinoma. We can move more peripherally. This is a lesion of the middle lobe. Well, it's possible to insert the echobronchoscope in the middle lobe. You can see this round lesion very close to the medial segment of the middle lobe, and very easy to visualize this round lesion. And you can see here also the fluoroscope that show that the tip of the echobronchoscope, the echo probe, is very close to the round lesion that in this case was a carcinoid. And here is another lesion in the lateral segment of the middle lobe, and again inserting your echobronchoscope in the lateral segment of the middle lobe, you can visualize the lesion. And you can see here the fluoroscopic view, the echobronchoscope inserted in the middle lobe, and the needle that penetrates the lesion to make sample. And in this case, it was an adenocarcinoma. Well, but even if the lesion is not very close to the highways, we know that it's possible to move the trachea, to move the bronchi, and yet it moves like Galileo Galilei said some century ago. It was referred to the heart, but the trachea also can be pushed. Look at this case. The lesion is 1 centimeter, 1.5 centimeter distal from the trachea. But if we push our echobronchoscope in the trachea and we bend the tip of the scope, we can move the trachea toward the lesion, and the lesion can be visualized. And you can see here in fluoroscopy the bending of the trachea induced by the bending of the scope that induce the tip of the echobronchoscope to become in contact with this lesion. So don't forget this technique, even if there is 1 centimeter or 1.5 centimeter distance from the trachea or from the bronchi to the lesion. Well, Now we move to peripheral lesion. This is a question and a technique that is not very well known by a lot of interventional pulmonology. The tip of the echobronchoscope is 3 millimeter in diameter. So you can wedge the tip of your echobronchoscope in the periphery, in the peripheral subsegmental bronchi of the lower lobe, and you can visualize very, very peripheral lesion, like in this case, you can see here, there is a bronchus. If you look at the CT scan that is 5 millimeter in diameter, well, it's possible to wedge the tip of your echobronchoscope in this small bronchus and to visualize very well this lesion that was a carcinoid. We will see some other case of peripheral lesion. You can see here 8 millimeter nodule in the right lower lobe. Try to think, if such a patient come to your hospital, what do you suggest? What is the technique that you suggest to take a sample? Tomorrow you will look such a patient and you will realize that there is also a small bronchus, 5 millimeter, very close, less than 1 centimeter to the lesion. It's possible to insert the echobronchoscope in the small bronchus? Yes, it's possible. And look, this 8 millimeter lesion that is very well visualized and sampled using a normal echobronchoscope, not a small echobronchoscope, but all these cases, all the cases that I show you are performed with the normal size echobronchoscope. The diagnosis was a metastasis of urothelial cancer. This is another nodule, 1 centimeter. And again, there is a bronchus, but there is also a large pulmonary artery very close to the nodule. So it's possible to wedge our echobronchoscope in this bronchus, to visualize the artery, to visualize the nodule, and to take sample in a safe way without risk of punction or biopsy the pulmonary artery. And you can see here the fluoroscopic view. Moving on the left side, again, this is a peripheral nodule of the left lower lobe, and again there is a bronchus, large, more than 5 millimeter here, and it's very easy to insert the echobronchoscope in this peripheral bronchus and to diagnose a carcinoid. This is another similar case, similar location, left lower lobe, and again, it's possible to visualize the nodule. You can see here in fluoroscopic view the echobronchoscope wedged in the periphery of the left lower lobe and the needle that is taking material from this lesion that was an adenocarcinoma. Again, very small nodule, 1 centimeter, but again, there is a bronchus very close to the nodule. Here is the fluoroscopic view. Here is the needle. Here is the nodule, very well visualized using the echo. And diagnosis was, in this case, a metastasis of melanoma. And look at these other patients. The lesion is very close to the diaphragm, in the periphery of the left lower lobe. There is a bulla very close to the nodule. So the risk of pneumothorax performing a percutaneous needle aspiration is quite high in this case. But if we put our echobronchoscope in the periphery of the left lower lobe, we can visualize very well the nodule, and we can sample the nodule without risk of pneumothorax and in a safety way. And again, it was an adenocarcinoma also in this case. This is a lesion very close to the diaphragm. Look at the echobronchoscope, and this is the lesion in fluoroscopic view. This is the sample, and this is the diagnosis. That was an adenocarcinoma. And this is a very recent case that we performed at San Raffaele Hospital some weeks ago, a lesion adjacent to the pericardium. And it's very nice image of echo bronchoscope inserted close to the lesion that make visible the pericardial sliding. Here is the pericardium, is the cardiac structure, and here is the lesion and the lesion. It was a metastasis of breast cancer in this case. We collected 30 patients with a peripheral nodule less than 3 centimeters, and we published our results using a linear echo bronchoscope for the diagnosis of such nodules. And this is a recent paper that we published on the first 30 patients. And you can see that we had the sensitivity on 92.8%. That is a sensitivity for peripheral nodules less than 3 centimeters that is greater than with the use of any other guidance system, including radial EBUS, including also robotic bronchoscopy. The only limit of this technique is that it can be used just for lower lobe nodules, because there is no possibility to wedge the echo bronchoscope in the upper lobe periphery. The esophagus is a separate way through the thorax and is a new way for interventional pulmonology. It's very easy to insert the echo bronchoscope into the esophagus, very easy to perform sample because there is no cartilage, no cuff. The procedure is better tolerated by the patients. We can reach lymph node station non in contact with the airways, like station 8 and station 9. But we can also sample paraesophageal lung lesion, paraesophageal lung lesions, paraesophageal pleural lesions, but also liver metastasis and left adrenal gland metastasis. For the first time, the bronchoscope was able to go behind the thorax, as we wrote in an editorial in Respiration some year ago. And some example of the transesophageal diagnosis of pulmonary tumor. You can see here a nodule very close to the esophagus, and the echo bronchoscope was inserted into the esophagus, and you can see here how it is easy to verify the position of the lesion, to insert the needle and to take sample. Another lesion, and also the esophagus is moving like the trachea. Here there is 1 centimeter distance from the esophagus to the lesion. It's possible to bend the tip of your echo bronchoscope to push the esophagus toward the lesion and to make a close contact between your instrument and the lesion, and take sample. And here's a huge mass of the left upper lobe, and again more close to the esophagus than to the trachea, and very easy to visualize this mass through the esophagus and to take a sample. Well, don't forget also, this is another paraesophageal pulmonary lesion, a huge mass. This is not difficult to perform, it's very easy. Don't forget the possibility also to sample pleural lesions. Like in this case, you can see this pleural plaque that was PET positive in a patient that 2 years before underwent right upper lobe lobectomy for adenocarcinoma. This pleural plaque is very close to the esophagus and very easy to visualize with this technique that got the acronym of EBUS-TBNA, and endoscopic ultrasound fine needle aspiration with B, that means using a bronchoscope. You can see here the pleural lesion, and the needle inside, and it was unfortunately a location of adenocarcinoma. Again, pleural lesion, pleural mass, very close to the esophagus, very positive at PET scan. You can see here the pleural masses well visualized through the esophagus with the use of an echobronchoscope inserted into the esophagus, and in this case, the diagnosis was mesothelioma. This is the normal appearance of a left adrenal gland, like a bird, using your echo endoscope inserted into the stomach, and this is the appearance of a left adrenal gland metastasis that can be sampled using your echo bronchoscope, and in this way staging also the parameter M of lung cancer. What about endovascular lesions? There are a lot of papers, and one is recently published by Venerino. Venerino, I was unable to insert your paper here, but you published a very nice case of pulmonary artery sarcoma diagnosis with EBUS-TBNA, because we can visualize the vessel, like in this case, and you can see here pulmonary embolism visualized using an echo bronchoscope, very close to the pulmonary artery, and you can see here a neoplastic embolus inside the pulmonary artery visualized using the echo bronchoscope. So, it's very important when we sample material using this technique to remember that endobronchial ultrasound guided transbronchial needle aspiration is enough for NGS sequences and for identify all the mutation and all the molecular characteristics that are necessary for the treatment of lung cancer, EGFR, ALK, PD-L1 expression. But to get these results is very important, the treatment of the material. For every case that we perform, we use both smeared cytology and
Professor, I think we are running out of time, yeah.
Yes, I finished. This is the last slide. Core biopsy and cell block. You can see here how many material is possible to insert in the formalin for cell block evaluation using a needle aspiration. Well, to conclude, EBUS-TBNA changed our diagnostic approach, increasing the sampling possibility of bronchoscopy. It is a very useful means for lung cancer staging, but also an invaluable instrument for diagnosis of several pathological conditions involving not only lymph nodes, but also other structures close to the airways and to the esophagus. The correct management of the material is, of course, a necessary requirement to get a good diagnosis. Thank you very much for your attention.